So moving on to the next session, that's a panel discussion. I would request the moderator for the session, Dr. Saurabh Kumar Das. Dr. Saurabh Das is a senior consultant at Max Hospital, Shalimar Bagh. He's publicized more than 24 publications in one book. He's also founder secretary for Oncocritical Care Society and founder editor Oncocritical Care, founder secretary ISPEN Delhi chapter, convener Thesis Wizard. His special interest is in research methodology, oncocritical care, and critical care nutrition. Welcome, Dr. Saurabh. Over to you.
Thank you. So, should we drink before eating or we should eat before drinking? Oh, this is not question for actually. I am asking myself. Huh? Sorry? You stop drinking. Okay. So, now we'll discuss some about fluid therapy. And we have understood that fluid therapy can save life from our experience during cholera epidemic. And 2001, Emmanuel River also showed that fluid therapy and antibiotic can save life in patients with sepsis. But over time, we also have realized that excessive fluid can also increase mortality and morbidity. So fluid therapy is tricky. To learn these tricks and pitfalls about fluid therapy, we have invited 3 brilliant minds in the field of critical care, particularly in the field of fluid and hemodynamics. We have Dr. Supradip Ghosh, Dr. Supradip Ghosh is Director and Head of Department Critical Care in Fortis Escort Hospital. He has wrote a book on fluid and it was published recently in 2022 and he had more than 21 journals. He also founder of Fluid Academy of India. He is the true fluid man of India. Dr. Supradip, please come and have your chair. We have Professor Dr. Anirban Choudhury. He is in Anirban Hospital. He has numerous publications and his areas of interest are mechanical ventilation, sepsis, clinical research, law, and I think also fluid and hemodynamics, right? We have Dr. Shrikant. We all know him. I always like his talk on hemodynamics. He is currently consultant and head of critical care medicine in Manipal Hospital, New Delhi. He is also associate editor of IGCCM, and his special interests are point of care ultrasound, extracorporeal life support, and advanced mechanical ventilation. So, to moderate the session, I have framed some questions. I will ask questions to one panelist, but another panelist also can, other delegates also can comment on them. So my questions are based on these three premises. First, fluid is a drug. So like any drug, it follows 4D. What is the drug? What is the dose? What is the duration? And when to discontinue. In ICU, when we deal with critically ill patient with shock, they are a kind of mixed type of shock. They may have some hypovolemic component. They also may have some vasodilated component. Which component is more, we don't know. And we extensively use dynamic variables for fluid responsiveness. And also, surviving sepsis guidelines, it recommends to use it while during fluid resuscitation in patient with septic shock. I would like to start with physiology of fluid dynamics. We all know Starling hypothesis. In 1896, Ernest Starling, he hypothesized that filtration is fluid is due to the hydrostatic pressure and absorption of fluid is due to the oncotic pressure. But now with the advent of new technique, we have come to know that there is no absorption across the vascular bed. There is only filtration. Whatever absorption of fluid occurs, it occurs to lymphatics. And whenever the volume expansion by crystalloid and colloid, they are almost similar. When you give fluid, whether the fluid will be remain in the vessels or it will be leak out, it will depend upon whether the vessel is filled or it is full. Again, we have also realized that endothelial glycocalyx is a very crucial for vascular integrity, and it can be destroyed by sepsis, by inflammation, by hyperglycemia, by hypervolemia, etc. So my question to Dr. Supradip Ghosh is that what are the clinical implications of revised Starling hypothesis?
Okay, it's very interesting. There are few caveats to the reversed Starling hypothesis itself. Is it really a revised Starling hypothesis?
They can also extend
It is extended Starling hypothesis. They have actually made Tom Woodcock has propagated things. And in fact, the Starling hypothesis was not made by Starling. It was made by somebody called Dr. Landis in 1926. Starling has given the concept that hydrostatic pressure and osmotic pressure. But the equation is what we see now was given in 1926, I think, if I remember correctly, by Dr. Landis. And this hypothesis reversed. Only Starling gave two compartments, intravascular and extravascular, this interstitial compartment. And Woodcock and his colleagues, they have added one more compartment of subglycocalyx.
I think they are father and son.
And there is Woodcock. The question is, all these revised Starling hypothesis, unfortunately, has not been proven in large mammals. So we still need more data. Now coming to the clinical implications, there are two things I can think of. There are maybe more. One thing is if we give hyperoncotic fluid, like or maybe something like 20% albumin, or giving gelatins or hydroxyethyl will it absorb the interstitial fluid or not? The Starling hypothesis, if we go by the revised Starling hypothesis, that is not possible, because subglycocalycial compartment is now at the junction between thing is the subglycocalycial compartment. So because it's a low protein, so there will not be absorption. But we have enough clinical data, and in fact, I am doing one study now based on this, that you give 20% albumin, there is enough clinical data to show that it increases the intravascular volume by, if not twice, at least 1.5 times.
Like how do you
remains more than 6 times? So because this revised Starling hypothesis, whatever, was derived from small mammals, that probably we still have more data. And this was done in static circumstances, whereas sepsis and other critical care conditions are dynamic circumstances. Second clinical implication could be, so my thing is, this revised Starling, as per revised Starling hypothesis, giving 20% albumin will not produce any increase in the intravascular volume but probably we do not have clinical data supporting it. In fact, large number of even randomized controlled, as recent as SWIPE trial, has shown that it actually improves the hemodynamics. Second hypothesis was, because of this, that you destroy the glycocalyx, the fluid will leak out, and within 10 minutes, 40% of the fluid volume will be dissipated to the interstitial compartment. That also has not been proven by, it has not been replicated in other clinical trials. So I think Professor Ram was the one who actually propagated that you give, because the glycocalyx will get destroyed, so 40% of the volume will be dissipated within 5 minutes or 2 minutes or 3 minutes, I don't remember, so quickly. But this same data has not been replicated in other studies. So just to conclude that, from my point of view, I think we need more data to prove or disprove these revised Starling hypothesis. As of now, as a clinician, I think I still will go by the conventional thinking of, okay, at least in some way or other, they help.
So you think there is still like oncotic pressure difference between the vessels, extravascular pressure and intravascular pressure? Because in electron microscope, they find there is the amount of protein, the albumin, it is almost same between the intravascular and extravascular, and there is no difference. That's why there is no fluid absorption. One is glycocalyx and other is this also.
So this electron microscopic picture, I am not denying the existence of glycocalyx. Yes, that it is there. I am not denying the fact that glycocalyx are important. They are important. But whether glycocalyx and subglycocalyceal compartment will be solely responsible for fluid exchange between interstitial compartment and intravascular compartment, that is where I am putting the question.
Thank you. My next question is to delegate. Like, why do you give fluid? What do you think? What is the purpose of giving fluid? Usually we give fluid to increase cardiac output, and we hope this increase of cardiac output would increase tissue perfusion and also improve oxygenation. But any fluid that does not cause increase of cardiac output is useless fluid, and useless fluid is a potentially harmful fluid. So we want to check before giving fluid whether this will increase cardiac output or not. So we use various dynamic variables like IVC, PLR, stroke volume, you all know. But in sepsis or in many conditions, increase of cardiac output not necessarily will increase tissue perfusion or oxygenation. So like we are only looking at one aspect of thing. If disease does not increase tissue perfusion, then also it is a useless fluid, and it also may potentially harmful. It is like sending ammunition to front line to win a war, and you don't know what about the soldiers, like what NATO is doing in Ukraine. So my question is to Dr. Anirban, whether we should consider also tissue responsiveness to cardiac output, not alone on fluid responsiveness.
Okay, thank you for your question, Saurabh. It is very clear that whenever we are administering fluid, we are administering the patient is on the steep part of the slope. And when we are administering on the steep part of the slope, we are expecting the cardiac output will improve. And consequent upon the improvement of the cardiac output, the tissue perfusion is going to improve. It is good, it is important, or there should be no mistake in determining that the patient is on which part of the slope, although it is very difficult. Now, if you ask me that whether the patient is fluid responsive, so patient's fluid responsiveness and cardiac output responsiveness may not always mimic. The patient may respond to fluid, but despite responding to fluid, the cardiac output may not increase because the effect of fluid responsiveness is very short-lived, and the cardiac output's effect is long-lived. So this much of short-lived effect will not produce a sustained increase in cardiac output. So by the time when you measuring cardiac output after administering the fluid,
actually, our assumption is that these dynamic variables, they reliably assess the cardiac output. They can predict. We are thinking beyond that, whether the increased cardiac output will also be helpful if it is not increasing tissue perfusion.
So whenever we are using fluid responsiveness, we are actually measuring the cardiac output. That is, whether we are doing passive leg raising, we are measuring its effect on the cardiac output.
Only cardiac.
Whenever you are using, it is not just the diameter of the inferior vena cava, that is more than 50%, less than 50%. But at the same time, we also have to use that whatever that we are using, whether it is accurate, because there is. So what happens if there is the lung compliance is not good? Whatever if the tidal volume, the ventilation is it is at a low tidal volume ventilation. So all these things should be kept in mind. And if you keep all these things in mind, probably passive leg raising monitoring cardiac output and scores over others in terms of, and also if you can measure the echo, if you put the echo at the level of the left ventricular outflow tract and see the VTI, so that will be a more usefulness than mere fluid responsiveness per se, because fluid may not indicate exactly or accurately to what extent the perfusion has improved, but which can be a major determinant if you are able to monitor cardiac output.
Any comment from
I think a more relevant point for a clinician is fluid responsiveness means automatically means it by definition is the cardiac output responsiveness. But whether cardiac, just by increasing the cardiac output, whether the DO2 will increase or not, delivery of oxygen to the tissue will increase or not. Second thing, whether by improving the macro hemodynamics, the micro hemodynamics will improve, which is something called the hemodynamic coherence. So let's come to the DO2 first. So say fluid responsive, where we give some fluid, so cardiac output will increase. But does it automatically mean that DO2 will increase? DO2 depends on many other factors like hemoglobin, oxygen saturation, and the hemodynamic coherence. We often see that after 24 hours or being in shock, the patient doesn't respond to anything. Even if we increase the mean arterial pressure, increase the cardiac output, the microhemodynamic doesn't improve.
Yes.
Microhemodynamic doesn't improve, then that means there will not be any improvement in the lactates, there will not be improvement in the capillary refill time. So here is probably the problem.
We always consider tissue perfusion before giving fluid. We don't rely on fluid responsiveness. There is always some sign. We have to find some signs of tissue hypoperfusion. Then only we think of giving fluid. But my question was that, like we do fluid this test because we want to mimic giving fluid. We don't want to give fluid and want to see the response. Similarly, but to whether this will improve tissue perfusion or not, till now I think we don't have any test. That can be done without giving fluid. So I think we need more.
We have to rely on the downstream parameters. So these are upstream parameters: blood pressure, heart rate, CVP. So all the downstream parameters like lactate, this,
Right,
that.
right.
So we will have to rely on the
But
ultimate goal is to
again,
improve the DO2.
Lactate clearance will be there, but for that you need to give fluid. That is a problem. Okay. So coming to the next questions. Yeah. No. Okay. So. Kumar, yes.
So I have a question for you. You mentioned about the glycocalyx and all. So should we administer fluid based only on fluid responsiveness? Sometimes the cardiac patient is also cardiac output responsive, especially in dengue grade TA, SDF, or in severe leaky capillaries. What would you do, sir? The leakage is so high.
Yes. We have a question. We have that. We'll come to that. So बाकी है. So this meta-analysis I did like 7 years back, and that time I tried to look at fluid unresponsiveness. Most of the time the people see at responsiveness. So many of my friends, colleagues, they question me, why did you check for unresponsiveness? Even I discussed with Professor Vincent, he also was not happy with that idea. Then I discussed with Professor Monet, and he was encouraging, and he also became a part of this analysis. But honestly speaking, I have also a doubt whether we should check responsiveness or unresponsiveness. So I want to take this opportunity to put forward this question to Dr. Srinivasan.
Okay, so you had specifically mentioned about inferior vena cava. Are we talking about that topic, or we are talking about it in general?
Anything you can do.
So let's take it in both parts, in general and with regards to the tests which you are talking about. So at least when you want to start giving fluids, your first thought is whether this X bolus of fluid or X amount of fluid is actually going to bring about an increase in cardiac output, with which you hope that the tissue perfusion is going to increase. So we give fluids with that thought process only. And we go with the presumption that all of them, as Anirban said, is on the rising part of the Frank-Starling curve, and he should be in some effect fluid responsive. The idea is to increase the preload or by increasing the mean systemic filling pressure. So what it does is increasing the stress volume, so we have a better venous return, the increased cardiac filling is occurring, and that is going to reflect as an increased cardiac output, and hence probably a better perfusion to the tissues. But as Dr. Supradip really pointed out, that's just one part of the story in which it may or may not reduce. So increasing pressures not necessarily means increasing the preload. Increasing the preload doesn't necessarily mean increasing the cardiac output, and increasing the cardiac output doesn't necessarily mean improving pressures. But what is the solution we actually have in hand? For a patient who comes in the shock, the first therapy we go is for fluid responsiveness. There are tests, dynamic vis-a-vis static. Static are useless, more or less, but dynamic, that is, problem is with the dynamic test, the applicability, at least with regards to stroke volume variation, pulse pressure variation, and all those, and tidal volume challenge and all, these are all only applicable to 6 to 15% of the population. You need low tidal volume ventilation, standardized pressure swings within the thoracic cavity, patients sedated, deeply sedated or paralyzed. That's a very small percentage. The vast majority are spontaneously breathing and patient is in shock and you are on NIV, the patient is struggling, he's acidotic. The pressure swings are going to be enormous, the intrathoracic pressure swings, and none of these dynamic variables will really be very, very reliable, including your IVC variability in a spontaneously breathing patient who has variable pressure swings in the thoracic cavity. So the same fallacy comes for the IVC variability also. So they can only provide one part of the story to you, but the true response will probably be with giving a bolus of fluid and seeing the response. Now you can do a reversible test like a passive leg raise, or you can actually go in for a fluid challenge. We can also tweak that by giving what's called a mini fluid challenge, which is like giving the same fluid at a very rapid rate. So the studies will say that faster giving fluid will mimic the same response as giving a larger volume of fluid. So we know large volume of fluids is harmful, so rather give a small volume at a much faster rate. So you have a very dynamic test, you challenge the system, you see the response. Now the question of fluid unresponsiveness will start coming in when you have crossed your basic barrier, because see, for every person you're giving a fluid, it has to be individualized. You can't really go in giving X amount of fluid to every single person. 20 ml per kg or whatever you want to give cannot be given to every single patient. You need to have an idea of how much the heart is going to take that amount of fluid. Elderly, diastolic dysfunction, post-systolic function, they will not take the 20 ml per kg. So you need to have a baseline idea of what exactly is the status of the patient, whether he is going to tolerate this amount of fluid or not. And if he is not going to be tolerant, then the question of fluid unresponsiveness comes into the picture, where you have to start looking for at the same time, while we are giving the fluid, whether this patient is going to go show signs of intolerance to fluids. Intolerance to fluid is appearance of pulmonary congestion. We can see on the ultrasound in the form of B lines. So both these things will actually go hand in hand. You're giving fluids with the hope of responsiveness, at the same time looking for signs of unresponsiveness. Those who have obvious signs of unresponsiveness or obvious contraindication to large volume fluids, may it be a poor cardiac function, may it be a person who is already in fluid overload or having signs of failure. In those patients, probably you will not go in for a challenging kind of a test. You rather go for a reversible kind of a test. And for everybody else, where you're starting to give fluids, you should always have a sign for whether there is any other further fluid therapy is required or not, and the patient started to become fluid unresponsive. Now I'll come to the point of the IVC. You were absolutely right when you said having no variability would probably be a very good idea. But see, even IVC for that matter is it's not the go-to test as we all believe that variation hai kar do. No, it's not so. IVC basically is just a surrogate of the right atrial pressure. Okay, so it's a back pressure from the right atrial pressure, and you're using the respiratory variation as the dynamicity of that test. Just like any other dynamic test, it has its own fallacies, has its own limitations, has procedural problems also to see the IVC, where to take the measurement. If you're not accurate in your measurements, you're not taking it obliquely, you're taking it from a distance. Patients with raised intra-abdominal pressures, patients with intrathoracic extreme amount of pressure swings, in all those cases, the IVC will become totally unreliable. Patient with pre-existing right heart failure, IVC is totally unreliable. So you may have a well-compressing IVC, and still the patient may be fluid unresponsive, and on the same time you have a totally dilated IVC, and still the patient is fluid responsive. So it is just one part of the story. The IVC cannot be seen in isolation. It has to be seen along with the function of the heart and along with the status of the lungs to have an idea of whether the patient is getting fluid unresponsive or not.
Yeah, I understood your point very well. But what was my explanation was that, suppose if you do an IVC collapsible test in mind, you don't give, even if it's collapsible, you won't give fluid. You will give fluid when there is some clinical criteria. I am in tachycardia, I am in shock. And if a young adult man, when there is signs of hypoperfusion, you even won't check the IVC. You just give fluid.
Yes.
But if the same thing happens to a 8 years old adult, where you think that he might have some low cardiac EF, and she may be fluid unresponsive, here you check the IVC. That's why I thought that we see mainly fluid unresponsiveness than fluid responsiveness. Or you check after giving some amount of fluid, then you want to see. That's what I said.
So you are checking for responsiveness, at the same time unresponsiveness every time you give an additional bolus of fluids. If everything of the patient's condition screams that the patient is not going to be responsive to fluids, you rather not give fluids. This includes a global assessment of the heart, includes the IVC as one part of it, includes the assessment of your lungs and other parameters as well.
Yeah, right.
So it's not just one thing in isolation. It has to go hand in hand.
Correct.
There is a beautiful, if you have an arterial line in place,
Yes.
if there is any youngster, arterial line in place, and if your arterial line, the ABP waveform is not showing any variation, you don't have to calculate it.
Yes.
The 13%, 11%,
yes.
all those things are only for studies. In practicality, if there is no variation in the eyeballing, please don't give fluid.
Yes.
So that is what
Yeah,
is our
yeah, yeah,
responsibility.
yeah.
So you don't have to go for an IVC, you don't have to go for an SBC. Just see on arterial line, there is no variation. You don't give fluid. So this is unresponsiveness. As Shrikant said, unresponsiveness, no fluid.
Yes.
And at the same time, a variation can be in two conditions.
If there is a variation, it doesn't mean automatically that it is fluid responsive.
Yes, it could be right heart failure.
No
also.
variation, you are quite sure whether patient is spontaneously breathing or patient is doing AF or whatever this patient is doing. No variation means no fluid.
And
If there is a variation, yes or no.
Yes or no? No in the case case of right heart failure.
Yeah,
it is
the
actually
problem
can
is
have a
that
variation.
IBC is, I think, most easy to use. That's why I think it is most extensively used.
But at the same time,
But
it's the most abused also.
Abuse. No, no. If you see the sensitivity, even in my meta-analysis, I did along.
I am not, see, the patient, the example you cited, 80-year-old man coming with cardiogenic shock. Why even to go for fluid response,
No, no, no.
breathing
No, no,
200
no,
ml
no,
or
no.
300
No,
ml?
no.
Just
No,
go
I am
fluid
just thinking, we will be more careful while giving fluid in patients who are 80 years old. And with there we will do an IBC check to see whether he is responsive or unresponsive. I won't check it when patient is young and like young, healthy, apparently healthy looking patient. That's what I want to say.
I don't think it is a good idea to define the IVC testing purely on the basis of age, because it is the etiology is the important factor.
No, it's not age actually. Just when you are doubt whether my fluid will increase the cardiac output or not. That's what I.
So when you are not sure at which part of the curve is your patient, whether he is on the steep part or in the plateau part.
See, see, the idea is the IVC is just one part of the story. Okay, so it's not as if I'm going to decide my entire fluid therapy based on the IVC. So that will just give me an additional reassurance whether this patient may benefit from some fluid, or it will give me a state of caution that this patient may not benefit in case other parameters also sort of saying that not to give fluids to this patient. Right? That will be a better way to put the IVC.
So I'll move to the next question. Again, coming to Frank Sterling. This describe the relationship between the ventricular preload and stroke volume. Lots of it. But usually we assume that preload is synonymous with fluid responsiveness. But as you know, in patient with sepsis, there is decreased stress volume. So we can increase the stress volume either by giving fluid or by giving pressure or by giving both. So in that case, when my IBC is showing that they are preload responsiveness, how will I decide that it is vessel pressure responsiveness or fluid responsiveness or it is both? Question to Dr.
I think vasopressor responsiveness is a different thing altogether. Preload responsiveness is what we think about the fluid responsiveness. Because ultimately, by giving fluid, you are increasing the preload only. You are only stretching the ventricular myocyte. So this is what it is. But vasopressor responsiveness is a totally different.
But preload can be also increased by vessel pressure.
Preload can be increased by vasopressors. Only few vasopressors. I take it. Like norepinephrine is one which can increase, but vasopressin cannot increase the preload. Norepinephrine, because it has got a venoconstrictive effect.
Yes.
So it can ultimately what we are doing with the fluid is we are trying to increase the stress volume.
Yes.
We are trying to increase the stress volume. If we increase the stress volume, then we are supposed to have an increase in the mean systemic filling pressure.
Yes, right.
If there is an increase in the mean systemic filling pressure, the gradient towards venous return will increase, and thus it will increase the cardiac output. At the same time, if we give venoconstrictive agent, it will increase indirectly the mean systemic filling pressure, and thus it will increase the venous return and subsequently the cardiac output.
Sir, whatever you said, it is true. When this is a
but there is no way whether this patient giving norepinephrine will increase cardiac output automatically or not. There is no way to prove or disprove it.
Yeah. Now, what you said, it is true when it is pure hypovolemic shock. When it is septic shock, when problem is not
Hypovolemic
absolute,
shock,
not absolute deficiency of fluid. This is a relative deficiency of fluid. The problem is not that a fluid is not there. The problem is that tank is now big. Now we have to shrink the tank also. So that's why what I'm talking about. We have to convert more unstressed volume to a stressed volume.
So this concept of unstressed volume, converting unstressed volume to stressed volume is applicable only in vasodilatory.
Yes,
shock.
septic shock. Yes.
Maybe septic shock, maybe
That's right.
anaphylactic
Yeah,
shock,
yeah.
maybe post cardiac bypass. All those vasodilatory states you can utilize
yeah.
this. But definitely not in hypovolemic.
Yeah, that is a premise because hypovolemic shock, it is very simple, give fluid. But because in our ICU we don't know that patient in hypovolemic shock or in septic shock. It is a mix shock. And where we need these tools most, they fail. There is a problem.
So there is a practical way of giving the vasopressors in whatever shock you are dealing with. One thing is diastolic. Look, if you diastolic blood pressure. If the diastolic blood pressure is less than 50, give vasopressor. Start vasopressor immediately. If the pulse pressure is very minimal, the difference between systolic blood pressure and diastolic blood pressure, that means there is a decrease in the, indirectly reflects the stroke volume is decreased. You give fluid fast, give vasopressor later. If you are suspecting there is a vasodilatory shock and you have already given a liter of fluid, then also it is time to start the norepinephrine instead of waiting for the. But there is no way we can find out whether giving a norepinephrine will increase the cardiac output or not. It is only trial and
sir, that's why the language of the guidelines also changing. Initially, give fluid if there is no improvement of hypertension, then start NORAD. But now here you can start simultaneously.
Now it is changed. Now it is the early use of vasopressors.
Yeah, we're coming to the next question. This is only extension for you only. So, as you we already discussed, give lots of fluid, but as you know, it is not a purely a hypovolemic shock. It is a some component is also visual shock, or at best we can say it's a mixed shock. It has both hypovolemic and vasodilation component. So this sensor trial was published before COVID time in Thailand, and they showed that early use of pressure causes early resolution of septic shock. And later on this trial, Clover trial, Keswick trial, they came, and but this trial did not show any mortality benefit. So I want to ask you how to interpret this study. Yes, it is restricted fluid does not decrease mortality, but it's also true that liberal fluid also does not decrease mortality. Then why to give extra fluid? Secondly, the difference between the two groups, the volume, the amount of volume is somewhere between 2 liter to 1.5 to 2 liter. Is this volume is not large enough to be lethal?
Yeah, very well. See, the main thing you have to understand when you interpret the studies is that it always talks about all-cause mortality. It is not a specific mortality that we actually look for, or which can attribute it either to the excessive use of fluids or to the. It is all-cause mortality. Number two, liberal fluid is a concept which has found many pitfalls, and as years pass on, the number of pitfalls seem to rise in geometric progression. So what is all those mnemonics that we come across, more is less, less is more. So all those things have come up because liberal fluid has been challenged a number of times, and almost all the times they had a sound physiological basis. Whatever these trials have shown on the decreased mortality can be accounted that when we all cause mortality, that finally we have failed to deliver our DO2. So in any case, whenever we are using vasopressors, whenever we are seeing the diastolic dysfunction to be present, whenever we are doing an echo, that is a good enough indicator to say that how much our vasopressors are working, whether we need to add a single to a second vasopressor or not, how much we are falling short in maintaining the map, or how much we are falling short of ultimately delivering the oxygen to the tissue level. So this micro circulation is very important. And unless and until we are able to relate our patient's clinical course to the improvement or deterioration in the microcirculation, we are looking at the all-cause mortality rate from 5 studies or a meta-analysis.
Give me a simple answer, because we want to practice. whether we should follow restricted fluid or liberal fluid.
We should practice restricted fluid irrespective of anything.
Because lack of evidence of crime is not a lack of crime. Right? We need till now we don't have.
We should not follow neither restrictive nor liberal.
Adequate, right?
That is called a judicious
Exactly.
fluid.
Yeah. This term is there's a problem with the term.
I have a
agree.
feeling
Completely.
that
Completely. What is restricted? What liberal? Yeah, it should be adequate fluid. Yes.
these Angrez, they are every time changing their narrative
Yes.
just to
I agree
fulfill
completely.
their academic goals. You have to publish some papers and publish it and go to the next generation, and you
Agree.
we will call them to the conferences and so that they can speak.
100% agree.
I have a feeling this. What is liberal? What is restricted?
Yes.
Look at the way this Clover's trial and Classic trial. This is stupid.
Yeah.
Giving shall we give
Stupid is a hard
fluid
word.
because somebody has not passed, he has not peed for 0.5 ml per kg body weight per hour for 4 hours, so I'll give fluid. Does it have any context? It is stupid. So, and look at the differences between the two trials. This 1.5 liter, as you truly said, is 1.5 liter. There is restrictive versus further restrictive. We have to ultra restrictive. These are just to get published. I don't think these papers have got any rationale. They are just wasting the money. Rather, they should spend this money to the African children. That will be better.
Okay. Next time we'll. So this is the last question. How many of you use NS for research edition? You still use? Because NS is criticized because it is a acidic fluid. The pH is 5.5. That means it has 100 times more hydrogen ion than blood. It has lots of sodium, more than less chips, and also it has a very high pathological chloride level that can cause that may be cause renal dysfunction. So various studies were tried, and initial studies they mainly look at two things. One is mortality and one is kidney dysfunction. The initial two studies they showed that there are some improvement of kidney with that balanced salt solution, but none of the studies they found any mortality benefit. However, this recent meta-analysis they included 11 studies and they analyzed almost 34,000 patients, and they found that with normal saline there is 9% relative increase of death, and to 1% relative increase of death with balanced salt solution, and indicating that average effect of using balanced salt crystalloid to reduce the mortality. So now my question to Dr. Srinivasan, whether should we throw this NS or should we keep this, because this is very one of the cost factors there.
Yes.
Because NS is 10 times less cheaper than the balanced salt solution.
Yeah. See, given that the balance of the literature does not say that NS is as harmful as it's made it out to be, okay, at least with regards to renal dysfunction, but at the same time it is putting a rider on the amount of normal saline that you can give. The idea is not to give 6 to 8 liters of normal saline because that will be totally unphysiological, increase the hydrogen load, increase the chloride load, produce another kind of acidosis. I agree. In a subset of patients like neurosurgical, neurotrauma patients, probably a hyperosmolar fluid like normal saline would be better than a balanced salt solution because their brain edema is a realistic issue. Short of that, it's not as if we can generally need to throw away normal saline. You can give it, but to a specific limit. Now that we are talking about restrictive fluid strategy and not trying to go overboard in giving fluids, the good idea would be to at least, if you want to give boluses, you can give normal saline, but not go overboard with regards to the amount of fluid. Maintenance fluid, balanced salt solution would be a much better idea. And this is purely talking with regards to the cost. Because, see, I mean, the literature is still out that, at least the data doesn't really support that it is a very big difference in the mortality benefit or the kidney dysfunction, between both these kind of solutions. So at least my approach is continue with balanced salt solutions in most of the cases. But normal saline is not a very bad alternative. It's not as should be as maligned as you're maligning the starches. Like you give starch and at least 1 liter of starch in your kidney is going to take a toss. It's not going to happen like that. So that thought process should not be there that normal saline is an evil which cannot be given. It can be given, but in moderation. Now, what is a moderation is not exactly described. For example, the PLUS trial went up to 6 liters of normal saline without showing any major differences in the mortality or anything. The split went up to 2. Yes. So there is a good range, but still one has to use their own clinical sense and not to, because knowing that there is a problem related to normal saline, one should be selective about using normal saline in a specific subset of the patient. And in others, if you have a choice of balanced salt solution, then balanced salt solution should be the way forward.
Dr. Praveen?
Ringer selected is also
Exactly. That's also
and
balanced
is
salt
not
solution.
that costly.
Not that
Dr.
costly.
Praveen, can I take one more question? Not my question, Kamal's question. Huh? So, what Kamal tried to ask is that in ICU, in patient with probable pneumonia, I saw a patient is having hypotension and there is some swing in the arterial line. Then I gave fluid. And now there is no hypotension and swing has gone. But again, after some time, it again appears. So, should I give fluid again? How many times I have to repeat like this? One study was done, and Dr. Supradip also mentioned about this one study, and this study was done in patients with post-operative patient, and they found that effect of fluid bolus does not last beyond 10 minutes in normal patient, and in sepsis patient, in patient with sepsis, mostly it don't last more than 3 or 4 minutes. So at this point, what should we do?
Here we are looking for fluid intolerance.
Third vasopressor.
Yes.
No, but
think
here,
that's
that is fine. No? This is usually with this seeing at this wave, everybody will say give some fluid, give some fluid. No.
No, you should
Nobody
not
will say-
be looking at the waves.
There is no easy answer to this question. Absolutely. जिस दिन easy answer हो जाएगा मैं भी
The answer is not there. That's why I'm happy.
so
I don't
there is
know
no
that
answer to it.
thinking
But
process.
probably the best way is not to give fluids again and again just because there's somebody's fluid responsiveness. But I think starting vasopressor is maybe it will help.
Yeah.
Ultimately, you have to repair the glycocalyx.
Yeah. How?
Go inside the volume vessel and repair it. Stitch it.
Okay. Thank you.
Stitch it with the endothelium.
Any final comment from Dr. Anirban?
I think that whatever we have seen and whatever we have read and whatever recent evidences try to state, it is very clear that we have to go by specific methods. Never use all the modalities to check fluid responsive. Choose the modality which you are most conversant with and which has got maximum evidences. I would stick to PLR. I would stick to echo at the putting a echo at the level of LVOT. And if once or twice it is fine, otherwise we always have to go for early use of vasopressors, and followed by that monitor the downstream parameters to see whether your perfusion is improving and to what extent.
Dr. Srikant, final comment for 10 seconds.
I totally agree with what Anirban said. But if your vasopressors do not reach your target and your limbs are getting dusky, your vasopressors are going up, and you're seeing that there is still some chance of giving fluids, there are no signs of intolerance, as I mentioned to you, as Supradip has said, there's no sign of intolerance, then you can go in for another bolus of fluid at this stage. But you should understand, whatever boluses you're going to give, it's like karma is going to come back and bite you later on. Not you, the patient, because eventually that's all going to be cumulative fluid balance, and that cumulative fluid balance has its own set of issues. Worsening of oxygenation, worsening of oxygen transport, generalized bloating, overloading of patients, increasing abdominal compartment pressures, so on and so forth. Organ edema. So these are all issues which is going to cause multi-organ dysfunction syndrome. So fluid is a drug to be given cautiously. Start vasopressors early.
Yes.
Look for sign for intolerance at the same time as we are giving fluids. So it's not as if you give fluids and you look at the response later. You're looking at the response at real time as it's going on. So it's any sign of fluid intolerance, don't give further fluids. Start vasopressors.
Thank you. Thank you so much. I really enjoyed talking with you. I want to talk with more, but Dr. Praveen.
Thank you, Saurabh.
Inviting us, and thank you Rajiv Gandhi Cancer Institute for providing us with a beautiful hall and the good food and good company. Thank you.
Thank you so much, all the participants and the moderator. I would request now Dr. Praveen Kaur and Dr. Saurabh to felicitate the participants of the discussion. Dr. Saurabh Kumar Das, Dr. Supradip Ghosh, Dr. Anirban Choudhury, and Dr. Shrikant Srinivasan. Dr. Praveen, go. Thank you so much. May I now request Dr. Pinky Yadav to kindly felicitate Dr. Saurabh. You put in quite effort. Thank you so much. It was a wonderful session.